Hello everyone. Today we'll be talking about low birth weight. Low birth weight is defined as if the weight of the baby is less than 2500 gram. That condition is called as low birth weight. But if the weight of the baby is less than 1500 gram, then that condition is called as very low birth weight. Okay. And next thing is extremely low birth weight means if the weight of the baby is less than 1000 gram, then that condition is called as extremely low birth weight. Okay, so these three birth weight that doesn't depend upon the gestational age. Okay, then we'll be talking about types of low birth weight. In low birth weight we have preterm, IUGR, and both preterms and IUGR. Okay, so IUGR has two types, that is called as symmetrical and asymmetricals. And symmetrical means what? Symmetrical means that happens in first and second trimester. Okay, that proceed with first or second trimester, whereas asymmetrical IUGR that proceed after second or third trimester. Okay, and in symmetrical IUGR the causes are what happens, there are a genetic cause, and next thing is there is genetical cause and TORS infections. Okay, and in asymmetrical IUGR the causes are placental insufficiency, and there is maternal hypertension and maternal anemia. Okay, and then we'll be looking for anthropometric measurements after the delivery of baby. So in symmetrical IUGR what happens, head circumference, length, weight are equally affected, whereas in asymmetrical IUGR only head circumference remains normal but length and weight are affected, but length is more affected than the weight. Okay, then we'll be calculating ponderal index over here. Okay, ponderal index is defined as weight divided by length in centimeter cube. Okay, so in symmetrical IUGR what happens, length and weight are equally affected. Okay, so when this happens, then what happens, then the ponderal index is more than 2 in symmetrical IUGR, but in asymmetrical IUGR length is more affected than weight. So what happens, length is more. Okay, length is more over here, so that causes what, that causes denominator, that means that the ponderal index is less than 2 over here. Okay, so that is the things. And then we'll be talking about how we can feed the baby. Okay, so if the baby is between 34 above 44 weeks, in between 42 to 34 weeks, or less than 32, or more than 28 weeks. Okay, so we have different range of feeding over here. Okay, and then we'll be talking about mode of feeding and macronutrient supplementation over here. Okay, and then we have to do growth chart. Okay, so we have to do that things. Okay, so in this way we will proceed the low birth weight. Now we'll be talking in our note over here. Okay, so that means you can see over here, low birth weight is defined as birth weight of a baby less than 2500 gram at birth irrespective of the gestation age. Okay, low birth weight that is less than 2500 gram, very low birth weight that is less than 1500 gram, extremely low birth weight that is less than 100,000 gram. Okay, that is the things over here. So low birth weight is defined as birth weight of a baby less than 2500 gram at birth irrespective of the gestational age. Okay, and then we have types, they are preterm low birth weight, IUGR, or both preterms and IUGR. Okay, and this IUGR is means what happens, the IUGR means gestational age may be term or preterm, but baby is undernourished and undersize. Okay, and preterm low birth weight means what, if the baby born with gestational age that is less than 37 week completed weeks and 2500 gram weight. Okay, that is called as preterm low birth weight. And then we have both preterms and the IUGRs. Okay, now let us talk about types of IUGR. They are symmetrical and asymmetricals. Okay, symmetricals means symmetricals. Okay, so same things over here. So causes that is normally seen in first or second trimester. Okay, and then here second or third trimester. Okay, and then causes is genetic or TORS infection over here. Okay, here placental insufficiency. Okay, placental insufficiency and insufficiency. Okay, insufficiency, and then hypertension and anemia. Okay, hypertension and the anemia. Okay, insufficiency and hypertension and anemia. Okay, and next thing is here size decreases, here number of cells decreases. Okay, and then what happens, here circumference, length, weight equally affected, but over here what happens, head circumference, length, weight, these things are affected, but head circumference remains normal. So okay, and then we will be calculating next thing, that is called as ponderal index. So ponderal index means here is ponderal index, that is less more than equal to 2, but here what happens, that is less than 2. Okay, so this is the things over here, and then we will be moving forward over here. Okay, so same things over here occurs when insult symmetrical means occurs when the insult on the fetal growth is in early gestations. Size of the body, head, body weight and body length decrease proportionally. Genetic chromosomal causes torch infection. Asymmetric IUGR means occurs when insult on the fetal growth is in late gestations. Okay, size of the head normal compared to length, weight, body. Okay, pregnancy induced hypertension, placental insufficiency, maternal medical condition over here. Okay, so small for gestational age means statistical definition that denotes weight of the infant being less than 2 standard deviations or less than 10 percentiles of the population norms. Okay, major problems in preterm babies and those with intrauterine growth retardations are preterm babies and babies with IUGR. Okay, in preterm babies the conditions are, the major problems are hypothermia, parental asphyxia, respiratory. In respiratory we have hyaline membrane disease, pulmonary hemorrhage, pneumothorax, bronchopulmonary dysplasia, pneumonia, bacterial sepsis. Okay, FNAF prematurity, metabolic hypoglycemia, hypocalcemia. Hematologicals we have anemia, hyperbilirubinemia, feeding problems and poor weight gain. Okay, babies with IUGR we have parental asphyxia, meconium aspirations, hypothermia, hypoglycemia, feeding intolerance, polycythemia, poor weight gains. Okay, so what are the steps to prevent complication management? Okay, so we have 7 steps over here. Resuscitation for birth asphyxia, first step. In here we can do prepare for high risk of need for resuscitations. Okay, gentle resuscitations, use of CPAP. Okay, take extra care to avoid hypothermia. And temperature maintenance we have to do frequent monitoring and educating parents for need to check temperature, special attention to maintenance of the warm change. And then we can do kangaroo mother care. Okay, and then we have nutrition feeding, that is management, breastfeeding within 1 hour possibles, spoon cutlery feeding, IV fluids if unable to feed. Okay, that is nutrition feeding. And infection prevention means hand hygiene, asepsis, reduce the portion handling of the baby, reduce overcrowding, disposable sterile gloves, portion hygiene. Okay, metabolic balance means we have to correct glucose and calciums, we have to correct anemia and polycythemia. Hyperbilirubinemia management means phototherapy, monitoring baby means weight, feeding vitals. Okay, biochemical monitoring means appropriate place of daily care. Okay, more than 1800 means we can do home delivery. Okay, if no other complications, that means if 1500 to 1800 means secondary level newborn care, less than 1500 means tertiary level newborn care. Okay, methods. Okay, so how we can care the baby, how we can feed the baby. Okay, we have two things, that is direct and exclusive breastfeeding. Also that feeding also depend on two things, that is whether the infant is sick or not, feeding ability of the infant. Okay, so feeding ability. Okay, so sick infants. Okay, so sick infants can be given with first IV fluids, and then if the vital is stable, then what happens, we can give enteral feeding. Okay, so initially here IV fluids. If the baby is stable, then what happens, we can give enteral feeding. Okay, enteral feeding over here. Okay, and that is the things over here. So IV fluids and enteral feeding. Okay, so oral feeding should not be delayed over here. Oral feed should not be delayed. Okay, delayed in them without any valid reasons. Okay, so the sick infants are those who are suffering from respiratory distress, shock, seizures, symptomatic hypoglycemia, electrolyte abnormalities, renal cardiac failure, surgical condition of the gastrointestinal tract, necrotizing enterocolitis, hydropsutalis. Okay, so these are the things. So sick infants, they must be started with IV fluids, and also after the vital stables, what happens, we can give enteral feeding. Okay, this is the things over here. And then healthy low birth weight infants, enteral feeding should be initiated immediately after birth in healthy low birth weight infants with appropriate feeding method determined by their oral feeding skills and gestation. Okay, so ability to feed, this is the main thing over here. Okay, breastfeeding requires effective sucklings, swallowings, and a proper coordination between suck, swallow, and breathings. Okay, so these three things must develop. Normally this suck, swallow, breathings that matures at 37 weeks, but after 34 weeks they can learn these techniques over here. Okay, so these things is more important over here. This complex skills mature with increasing gestations, or robust sucking pattern is not present until 32 to 34 weeks of gestations. Okay, robust sucking pattern is not present until 32 to 34 week gestations. A coordination between suckling, swallowing, and breathing does not mature until 34 weeks of gestations. They fully mature by 37 weeks of gestation. Okay, so same thing over here. Okay, so let us write over here. Okay, if the baby is 28 to 32 weeks. Okay, so what happens, first thing, so there is no development of what? Development of suckling, swallowing, and breathing adequately. Okay, you see there is no coordination between these three things. So what happens? We cannot give breastfeeding. Okay, so then what happens? We have to treat the case, we have to feed the baby with firstly nasogastric tube. Okay, nasogastric tube. Okay, so orogastric tube. Okay, we can give orogastric tube. Okay, that is called as orogastric tube. Okay, these things over here, orogastric tube we can give over here, and then after reaching 32 weeks we can do palaidi or spoon feeding. Okay, after reaching 34 weeks we can give breastfeeding. Okay, so this is the things over here. So these three things we can do over here. If the baby is 30 to 34 weeks, then what happens? Initially we can do palaidi or spoon feeding. If then what happens? We reach 34 weeks, then we can do breastfeeding. Okay, and we'll be checking the swallowing patterns, okay, sucking patterns, and the breathing patterns. Okay, so these three things can be compared, and then we can give this palaidi or spoon feeding and then breastfeeding. Okay, and then lastly, after 34 weeks we should not do anything. So we will be checking the case first. Okay, we will be initial breastfeeding. If there is adequate sucking, swallowing, and breathing, then what happens? We can give breastfeeding. Okay, so this is the things over here. So same thing can be listed over here. Okay, so 34 weeks, more than 34 weeks, what happens? We can do initial breastfeeding. So observe if positioning and attachment are good, able to suck effectively and long enough. So, okay, so yes, that means breastfeeding. If no, we can do start feeds by spoon or palaidi. Observe if accepting well without spilling, coughing, able to accept adequate amount, means yes, spoon or palaidi feeding. If no, then what happens? We can do start feed by orogastric or nasogastric tube. So again, we will revise these things. If the baby is more than 34 weeks, initial breastfeeding. So okay, observe if positioning and attachment are good, able to suck effectively and long enough, then what happens? We can continue the breastfeeding. If not, then what happens? We have to start feeds by spoons or palaidi. Okay, observe if accepting that things, means that if there is no adequate breastfeeding after 44 weeks, also we can do spoons or palaidi. That is the mode of feeding the baby. Okay, in after 34 weeks. In 30 to 34 weeks, so initially we'll be starting with giving start feeds by spoon or palaidi. Observe if accepting well without spilling, coughing, able to accept adequate amount, means we have to give spoon or palaidi feeding, continue. If not, then what happens? We can do oral feeds by orogastric or nasogastric tube over here. Okay, so observe if vomiting or abdominal distension occurs. Okay, if that things happens, then what happens? We can do over here. Okay, we can continue with these things. If again there is what happens, if again we are doing orogastric nasogastric tube, or again we are doing these things, then what happens? This is the things over here. If again they are not feeding with the help of orogastric or nasogastric tube, then what happens? We'll be giving IV fluids, and then only we will be starting over here. Okay, so this is the things over here. And then how much to feed? Infants who are infants who are able to suckle effectively, breastfeeds will be breastfed on demand. Small babies usually demand to feed every 2 to 3 hours, sometimes more frequently. A small infant who does not demand to feed for 3 hours or more can be offered for the breastfeed and encouraged to feed. Infants who are fed by spoons or palaidi or by intragastric tube, it is essential to know how much to feed, the amount of express breast milk to be given for those infants who are on alternative methods of feeding like gavage or spoon feeding. Okay, preterm infants need more fluids in the initial week of life because of high insensible water loss. It is usually clinical practice to provide very low birth weight infants about 80 ml per kg fluids on the first day of life, increased by 10 to 15 ml per kg per day to a maximum of 160 ml per kg by the end of first week of life. Okay, low birth weight infants, that means more than 1500 grams, are usually given about 60 ml per kg fluids on the first day of life, and fluid intake is increased by about 15 to 20 ml per kg per day to the maximum of 160 ml per kg per day by the end of first week of life. After deciding the total daily fluid requirement, the individual feed volume to be given every 2 to 3 hours can be determined. Okay, now nutrition supplementations. Okay, that nutrition supplementation is to be done in the weight of the, if the weight of the baby is between 1500 to 2499 gram. Okay, after more than 34 weeks, means doesn't require any supplements. If the weight of baby, or if the period of gestation, that is between 30 to 34 weeks, then what happens? We can give calcium and phosphorus 160 to 140 to 160 mg per kg per day and 70 to 80 mg per kg per day respectively for infants on exclusive breast milk. Okay, also we can give vitamin D complex, vitamin D that is 400 international unit per day, vitamin B complex and zinc, okay, in the form of multivitamin drops. Folate also we can give irons, okay, and also we can give multi-nutrient supplementations, okay. They are calcium, phosphorus, vitamin E, C, okay. Also we can give the nutrients by the help of fortifications, okay. So criteria for discharge, okay, these are the things over here. So how, when we can discharge the baby? We have to screen the baby. Mainly we have to screen for retinopathy of prematurity. Also we have to do auditory brainstem evoke response over here, okay. And nutrition supplementation including mainly vitamins, iron, calcium, and vitamin D started. Immunization with BCG, hepatitis B, and OPV is given, okay. Weight gains should be checked, okay, and then should be recorded and plotted on the growth charts, and that need to be follow up, okay. Baby should be feeding well, absence of danger signs, okay. And also we have to give the mother confidence, okay. She must be taught about everything, and the mother should be confident regarding its details of feeding, okay. In absence of danger signs, we have to see about danger signs in infant, in neonates, okay. In method of temperature regulations, other KMG practice or other methods should be well known to parents. All danger signs are explained in detail to parents with information regarding whom and where to contact clearly highlighted, okay. In this way we have completed pediatric low birth weight, okay. Thank you.